Imagine your body is, well, like a puppet, right? And your brain is the one pulling all the strings.
Right, setting the commands.
Exactly. You want to walk, talk, breathe, or, even just blink. Your brain sends this signal down the spinal cord, out through the peripheral nerves, and it tugs on the muscle.
A highly coordinated biological tug.
Right. But what happens when the strings don't snap? They just melt. Like, what happens when the signal reaches the very end of the line, just nanometers away from the muscle, and simply falls into the abyss?
It's a terrifying biological reality, honestly.
Welcome back to the Deep Dive, and specifically to Enkephalikos, my YouTube series where we explore diseases of the nervous system. Today, we are zooming in on a gap so incredibly small, you can't even see it with a standard light microscope.
Yeah, 50 nanometers. It's microscopic.
Right. Yet, if that tiny gap expands by just a few billionths of a meter, you completely lose the ability to move.
We spend so much time, thinking about the brain as this invincible supercomputer, or the muscles as these robust engines of force. But the entire system relies on this microscopic handshake between the two.
The neuromuscular junction.
Exactly, that specialized synapse. And when that junction fails, the resulting diseases are profound.
Which brings us to our mission today. This is part 2 of our 3-part finale on Chapter 57 of Kandel's Principles of Neuroscience.
The definitive textbook for this stuff, yeah.
Absolutely. We're tearing into the pathology of the peripheral nerve and motor unit, specifically how synaptic transmission breaks down. And, if you're listening to this right now, maybe casually sipping coffee or walking your dog, you might be wondering why you should care about a gap that tiny.
You should care because, well, by studying how these microscopic junctions fail, we unlock the hidden mechanics of how your own healthy movements are supposed to work.
Reverse engineering the machinery of human life.
Exactly. It isn't just a list of rare medical pathologies. When you see how a single rogue antibody or a mutant protein inherited from a parent can completely dismantle your ability to lift a finger or take a breath.
It's mind-blowing.
It really is. You begin to appreciate the staggering, almost precarious precision required for you to simply exist in a physical space.
So let's start with a disease that really put this microscopic gap on the map for neurologists. It's called Myasthenia gravis. Break down that name for us because the roots usually tell a story.
They do. So myo is Greek for muscle, and asthenia means weakness.
Okay, muscle weakness.
Right, and gravis is Latin for heavy or severe, so literally severe weakness of the muscle.
Which sounds pretty broad.
It does, but it's actually the most extensively studied disease affecting synaptic transmission in human history, and its clinical presentation is remarkably specific.
Right, because if I think of a classic muscle disease, like, say, a muscular dystrophy, I usually picture someone struggling to walk.
Yeah, or having trouble getting up from a chair.
Exactly. The weakness usually starts in the big muscles, the proximal limbs or the torso. But myasthenia gravis doesn't play by those rules, does it?
No, not at all. It attacks from the top down. It almost always announces itself in the cranial muscles first.
Meaning the muscles controlled by the brainstem.
Exactly. The cranial nerves emerging directly from the brainstem rather than the spinal nerves.
So we're talking about the eyes, the face, the throat.
Those exact ones. The most classic initial sign is ptosis, which is a drooping of the eyelids.
Just one or both?
It can be either. A patient might wake up looking fine, but as the day goes on, their eyelids just become these heavy curtains they literally can't keep open.
Oh, wow.
Yeah. And this is often accompanied by diplopia or double vision.
Because the eye muscles get weak.
Right. The extraocular muscles, the tiny ones that dart your eyes around, they weaken asymmetrically. So the eyes can no longer align perfectly to form a single image.
That sounds incredibly disorienting.
Very.
Yeah.
And later on, it might affect the oropharyngeal muscles, making swallowing or even speaking incredibly difficult.
And it only hits the arms and legs after all that?
Usually, yes. Only after these cranial muscles are compromised does the weakness typically spread to the limbs.
Which brings up a massive question. The absolute hallmark of myasthenia gravis isn't just weakness, right? It's fatigability.
The fluctuation, yes, that's the key.
Right, like a patient might test perfectly strong at 8 in the morning, but by 8 p.m., they can't even chew their dinner.
Or even during a 30-second test in the clinic.
Oh, really? Just 30 seconds?
Yeah, if a doctor asks them to just stare up at the ceiling without blinking, you can literally watch their eyelids slowly flutter and collapse.
That's wild.
Yeah.
But if there's a physical disease attacking the muscle, why wouldn't it just be weak all the time? Why the fluctuation?
Well, to understand that, we have to dive straight into the biophysics of how a nerve actually talks to a muscle.
Let's do it.
So in the most common form of myasthenia gravis, which is an autoimmune disorder, the patient's own immune system is producing antibodies.
Rogue antibodies.
Exactly. And they launch an unprovoked attack on the postsynaptic side of the neuromuscular junction. Specifically, they are hunting down and neutralizing the nicotinic acetylcholine receptors.
The chemical receivers on the muscle. Okay, so I've heard this described like a toll bridge before. Let's see if this analogy holds up.
Oh yeah, let's hear it.
The nerve terminal is the sending city. The muscle is the receiving city across the water. And the neurotransmitters, the acetylcholine molecules, are the cars trying to cross the bridge.
Makes sense so far.
And the receptors on the muscle side are the toll booths. So in this disease, the immune system is basically a wrecking ball destroying half the toll booths.
That's a pretty visceral image, yeah.
Early in the morning, traffic is light, so the remaining booths can handle the cars. But as you keep moving your eyes, traffic gets heavy, the remaining booths get overwhelmed, the cars back up, and the signal fails. Is that basically it?
It captures the what of the situation, the bottleneck effect. But it doesn't quite capture the how or the why of the electrical failure.
Because it's not just physical cars, it's electricity.
Exactly. A neuromuscular junction isn't just a physical bottleneck, it's an electrical threshold game. To really understand the fatigability, we need to talk about voltage. We need to look at the microscopic electricity.
Okay, let's get into the weeds then. Strip it down to the raw numbers. What is the electrical state of a healthy muscle fiber before the nerve even fires?
If you take a microelectrode and pierce a resting, healthy skeletal muscle fiber, you will find that the inside of the cell is negatively charged compared to the outside.
And this is the resting membrane potential.
Yes, and it sits at roughly negative 90 millivolts.
Negative 90, and that's maintained by ion pumps actively shoving sodium out and pulling potassium in, right?
Exactly.
So it's like a loaded spring waiting to be released.
A highly tensioned, loaded spring. Now, for that muscle fiber to actually contract to twitch and generate force, that electrical charge needs to flip.
The membrane needs to depolarize.
Right. But it doesn't need to flip all the way to zero immediately. It just needs to reach a very specific trigger point called the threshold.
What's the magic number for the threshold?
It's about negative 45 millivolts.
Okay, let me do the mental math here. We start at negative 90. We need to get to negative 45. So the nerve needs to deliver a positive electrical jolt of exactly 45 millivolts to pull the trigger.
That is the minimum requirement, yes.
Okay, so how does it deliver that jolt?
When a nerve impulse arrives at the terminal, it triggers thousands of tiny vesicles to fuse with the membrane, and it dumps millions of acetylcholine molecules into the synaptic cleft.
The car is crossing the bridge.
Exactly. These molecules diffuse across the gap and bind to those nicotinic receptors on the muscle. When they bind, the receptors act like trapdoors.
And what happens when they open?
They open up, and positive sodium ions rush from the outside of the cell into the inside.
And that rush of positive sodium is what causes the voltage shift. You called it the end plate potential in our notes.
Yes, the excitatory end plate potential, or EPP. Now, here is where the brilliance of human evolution comes in.
Oh.
You calculated that we only need a 45 millivolt shift to hit threshold.
Right. Negative 90 to negative 45.
But a normal, healthy nerve dumping a normal amount of acetylcholine creates an end plate potential of about 70 to 80 millivolts.
Whoa, wait. So it needs 45, but it delivers 80.
Yes.
That is massive overkill.
It is intentional biological overkill. We refer to this as the safety factor.
It's like if you need to wake someone up from a nap, you could just gently whisper their name until they stir. That's the threshold.
Right.
But the healthy nerve decides to hold a literal megaphone to their ear and blast an air horn.
That is a much better analogy. Absolute acoustic overkill.
Just to guarantee that the muscle wakes up and fires every single time, without fail.
Exactly. Because of that megaphone, that massive safety factor, synaptic transmission, can actually be reduced by up to 75%, and the resulting electrical shift will still be large enough to hit the negative 45 millivolt threshold.
Wow, so you have an enormous margin of error built into the system.
You do, but this is where the pathology comes in.
So how does the immune attack in myasthenia gravis erode that safety margin? The wrecking ball hits the toll booths, but what does that do to the voltage?
Because the antibodies have destroyed or blocked so many of those sodium trapdoors, the amount of positive charge that can rush into the muscle is severely limited.
So the electrical spike is smaller.
Right. The amplitude of the end plate potential shrinks. It drops from a robust 80 millivolts down to maybe 50 or even exactly 45 millivolts.
So the megaphone is gone. The nerve is now just whispering, barely hitting that negative 45 threshold.
Barely hitting it, yeah.
But if it's hitting the threshold, shouldn't the muscle still work? Why do we see the fatigue?
Because the nervous system isn't static. There are normal physiological fluctuations in how much neurotransmitter a nerve releases.
Oh, really? It doesn't release the exact same amount every time?
No, it doesn't. When you sustain a muscle contraction, like holding your arm out or staring at the ceiling, the nerve terminal is firing rapidly and repeatedly. As it does this, the store of immediately available acetylcholine vesicles temporarily depletes slightly.
So it runs a little low on ammo.
Just a little. The amount of transmitter released per impulse naturally drops as the contraction goes on.
I see it.
Yeah.
In you or me, that drop doesn't matter. The safety factor absorbs it.
Exactly.
The megaphone might lose a little battery power, but it's still deafening.
Precisely. But in the myasthenic patient, their baseline end plate potential is already hovering right at that negative 45 millivolt threshold.
They have zero margin of error.
None. So when that normal slight drop in neurotransmitter release occurs during sustained effort, the end plate potential shrinks just a tiny bit more. It drops to negative 46 or negative 48 millivolts.
It falls below the threshold. The trigger isn't pulled.
The muscle fiber goes completely silent.
And if this happens across thousands of junctions simultaneously, the macroscopic muscle just loses force. The eyelid drops. The arm falls.
It is a stunning cascade of microscopic failures translating into visible paralysis. And as a neurologist, you can actually watch this safety factor fail in real time using an electromyogram, or EMG.
Walk us through what that looks like on the screen. Because an EMG involves sticking a needle into the muscle and shocking the nerve, right?
Sometimes, but generally for this specific test, we use surface electrodes over the muscle and repetitively shock the nerve supplying it, usually at a low frequency, like 2 to 5 times per second.
Sounds incredibly uncomfortable.
It's not pleasant, no, but it's highly diagnostic. In a healthy person, if I shock your motor nerve 3 times a second, the electrical response from your muscle, the compound muscle action potential, will be completely identical every single time.
Because of the safety factor.
Exactly. Shock, big wave. Shock, big wave. The safety factor guarantees a uniform response.
But in the patient with myasthenia gravis?
In that patient, the first shock might produce a reasonably normal wave because they've been resting. But with the second shock, the wave is smaller. By the third or fourth shock, the amplitude of the electrical response rapidly decreases.
It just fades out.
We call this the decremental response. You are literally watching the end plate potentials drop below threshold on a graph.
It's the visual proof of the system giving up. Now, the text mentions a really dark historical parallel here. This decremental EMG pattern, this exact biophysical failure, it isn't just found in autoimmune disease.
No, it perfectly mimics the effects of a very specific poison.
Right. It's completely identical to a healthy muscle that has been poisoned by ditibocurarine.
Curare.
The famous plant extract used by indigenous tribes in the Amazon. They would dip their blow darts in it to hunt monkeys and birds in the canopy.
Right.
The animal gets hit, its muscles go limp, and it falls from the trees.
And the mechanism of that paralysis is brilliant and, well, devious. Curare doesn't damage the nerve, and it doesn't damage the muscle fiber itself. It acts as a competitive antagonist at the neuromuscular junction.
A competitive antagonist, meaning it fights for the same parking spot as acetylcholine.
Precisely. The Curare molecule has a shape that allows it to slot perfectly into the acetylcholine receptor on the muscle, but it doesn't open the sodium trapdoor.
So it just sits there.
It just sits there, blocking the actual acetylcholine from binding.
So myasthenia gravis is essentially endogenous curare poisoning. Instead of a plant toxin fired from a blowgun, it's your own white blood cells firing antibodies that block the receptors in the exact same way.
That is one of the mechanisms, yes. Though, as we look closer at the microscopic battlefield, we find that the antibodies in myasthenia gravis are actually much more destructive than simple curare.
Really? How so?
Well, curare just blocks the lock. The antibodies blow up the door entirely.
Okay, let's visualize that battlefield. If we were to take a biopsy of a myasthenic neuromuscular junction and put it under an electron microscope like figure 57-9 in the text, what does the devastation actually look like compared to a healthy synapse?
A normal neuromuscular junction is an architectural marvel. It is not just 2 flat surfaces facing each other.
It's more complex than that.
Much more. The presynaptic nerve terminal sits in a slight depression on the muscle surface. And the muscle membrane directly underneath it is heavily corrugated. It is folded inward into these deep, complex valleys called junctional folds.
Why the folds? Like, what is the biological advantage of a corrugated surface over a flat one?
Surface area and strategic placement. The acetylcholine receptors aren't just scattered randomly. They are incredibly densely concentrated, up to 10,000 receptors per square micrometer at the very crests of those folds.
Oh, so they are right at the top.
Exactly. They are positioned at the absolute closest possible physical point to where the nerve terminal releases the neurotransmitter.
So it's literally designed to make the chemical journey across the cleft as short and efficient as possible.
Yes. But when you look at the myasthenic junction under the electron microscope, that beautiful architecture is ruined.
What happens to it?
The junctional folds are simplified. They are shallow or, in severe cases, completely flattened out, like someone took an iron to the corrugated membrane.
And what about the physical gap between the two?
The synaptic cleft itself is significantly widened. The distance between the nerve and the muscle has increased.
So the whole structure is just wrecked.
Mostly on one side. Importantly, if you look at the presynaptic side, the nerve terminal, it looks entirely normal.
Oh, really? The nerve is fine.
Perfectly fine. The vesicles are packed with a normal amount of acetylcholine, and the machinery to release them is intact. The destruction is entirely postsynaptic.
Okay, so we have flattened folds and a wider gap. Why is a wider gap such a catastrophic problem? Acetylcholine diffuses pretty quickly, right? It's just a slightly longer swim.
It is a longer swim, but the water is filled with sharks.
Sharks?
We call this the diffusion problem. The synaptic cleft isn't just empty space. It is filled with a basal lamina, a mesh-like matrix, and anchored within that matrix is a highly aggressive enzyme called acetylcholinesterase.
The cleanup crew. Its job is to destroy the acetylcholine so the muscle signal doesn't last forever.
Yes. And acetylcholinesterase is one of the fastest enzymes in the human body. In a normal, healthy junction, the gap is so narrow, about 50 nanometers, that the acetylcholine molecules can shoot across and hit the receptors before the enzyme has a chance to hydrolyze them.
It's a race, and the transmitter normally wins.
But in the myasthenic junction, the gap is widened.
And the receptors at the finish line are sparse.
Exactly. Because the molecules have to travel further, they are exposed to the acetylcholinesterase for a longer period of time. A huge percentage of the neurotransmitter gets chewed up and destroyed in transit before it ever reaches the muscle membrane.
So not only are there fewer toll booths, but the bridge itself has been lengthened, and there are snipers picking off the cars as they cross.
That is an absolute logistical nightmare for the signal, yes.
Let's talk about the wrecking ball itself. How exactly are the antibodies causing this physical flattening and widening? You mentioned they don't just block the binding site like Curare does.
Well, while some do block the site, the vast majority of these autoantibodies do not. They are targeting epitopes, specific structural regions on the main extracellular domains of the receptor molecule.
And what happens when they attach?
Once they attach, they initiate two primary mechanisms of destruction. The first relies on the structure of the antibody itself. Antibody, specifically IgG antibodies, are Y-shaped. They have two binding arms.
So they can grab two things at once.
Yes. A single antibody can grab onto one receptor with its left arm and an adjacent receptor with its right arm. This cross-links the receptors together on the cell surface.
And why is that bad?
The muscle cell is constantly monitoring its own membrane, and when it senses these abnormally cross-linked clumps of proteins, it assumes they are damaged.
Oh, I see.
It triggers a process called endocytosis, internalizing that patch of membrane and degrading the receptors in its lysosomes.
The immune system essentially tricks the muscle cell into cannibalizing its own receivers.
It is accelerated degradation, exactly. The turnover rate of the receptors skyrockets, and the muscle can't synthesize new ones fast enough to replace them.
That's insidious.
And the second mechanism is even more violent. These antibodies act as flares, calling in the heavy artillery of the immune system, the complement cascade.
The complement cascade. That sounds like a polite biological pathway, but it's actually incredibly destructive, right?
It is ruthless. The complement system is a series of proteins that normally circulate inactive in your blood. When they encounter an antibody bound to a target, they assemble in a cascade, C1 through C9, culminating in the formation of something called the membrane attack complex, or MAC.
Membrane attack complex.
It lives up to its name. These proteins literally assemble into a microscopic tube, like a syringe, and punch a physical hole straight through the lipid bilayer of the muscle membrane.
They puncture the cell.
Yes. Water and ions rush in uncontrollably, causing localized lysis. The cell membrane bursts.
So it's literally exploding the surface.
Yes. This microscopic, repeated bombing campaign of complement activation is what physically destroys the junctional folds and widens the cleft. It is scorched earth.
That is horrifying. Now, there's a really important clinical caveat here. We've been talking all about antibodies destroying the acetylcholine receptors.
Right.
But there's a subset of patients who have all the symptoms of autoimmune myasthenia gravis. The drooping eyes, the fatigue, the flattened folds. But when you test their blood, they have zero antibodies against the acetylcholine receptor.
We call these patients SNARE-Negative. And historically, this was a massive mystery.
I bet.
But in recent decades, we've discovered that they do have an autoimmune attack happening. It's just directed at a different target in the same neighborhood.
What's the target?
In a large percentage of these SNARE-negative patients, the antibodies are attacking a postsynaptic transmembrane protein called MuSK.
MuSK. That stands for muscle-specific kinase.
Yeah. Muscle-specific receptor tyrosine kinase, yes. Or, in other cases, they have antibodies against a protein called LRP4, which interacts with MuSK.
Okay, let's puzzle this out. If the immune system is destroying MuSK or LRP4, but leaving the actual acetylcholine receptors alone, why does the synaptic transmission still fail? Like, what do those proteins actually do?
To understand that, you have to look at how a neuromuscular junction is built during embryonic development and how it is maintained throughout your life. The acetylcholine receptors don't just magically arrange themselves into those incredibly dense clusters at the crests of the folds.
Something has to herd them together.
Exactly. They have to be anchored there. And the signal comes from the nerve. The nerve terminal secretes a protein called egrin.
Egrin?
Egrin crosses the cleft and binds to LRP4 on the muscle membrane. LRP4 then activates MuSK.
And what does MuSK do?
MuSK acts as a mast organizer inside the muscle cell. It triggers a signaling cascade that grabs onto the acetylcholine receptors and tightly clusters them directly under the nerve terminal, anchoring them to the cytoskeleton.
So it's the construction foreman. The nerve releases the blueprint, the egrin. The foreman, MuSK, reads it and tells the workers to build the toll booths right exactly where the bridge is going to land.
That is a perfect way to visualize it. So if you have antibodies that neutralize MuSK or LRP4, the foreman is knocked out.
The clustering signal is lost.
Yes. Even though the acetylcholine receptors aren't being directly destroyed by complement, they are no longer anchored. They drift away, scattering across the muscle membrane.
And if they scatter, the density drops.
Right.
When the nerve fires, the neurotransmitter diffuses across the cleft, but the receptors are spread too thin to catch a concentrated dose. The end plate potential shrinks, and the safety factor fails, exactly like in the classic form of the disease.
The clinical outcome is identical, even though the molecular target of the immune crosshairs shifted by just a few nanometers.
Okay, we thoroughly mapped out the battlefield. We understand the biophysics of the failure and the molecular weapons being used. Let's talk about the counterattack.
The treat.
Right. How do we actually treat a patient with autoimmune myasthenia gravis? There is a series of photos in the Kandel text, figure 57-7, that blew my mind. It shows a patient with severe ptosis. He looks exhausted. His eyelids are heavily draped over his pupils.
A classic presentation.
He's given an injection, and then the next photo, taken just 60 seconds later, his eyes are wide open, completely alert. It looks like a magic trick. What was in that syringe?
That is the classic tensilon test using a drug called edrophonium. Edrophonium is a fast-acting, very short-duration acetylcholinesterase inhibitor.
Ah, it attacks the cleanup crew.
Precisely. Well, I should say it temporarily disables them. Remember, acetylcholinesterase is the enzyme in the cleft rapidly destroying the neurotransmitter. Edrophonium binds to that enzyme and stops it from working for a few minutes.
So we aren't fixing the receptors. We aren't stopping the immune system from attacking. How does paralyzing the cleanup crew give the patient their strength back?
It comes back to the diffusion problem and the game of statistical probability.
Okay, break that down.
In the myasthenic junction, you have a widened gap and very few receptors left. Normally, the acetylcholine gets released, and the enzyme destroys most of it before it can find one of those rare receptors.
Right, the snipers pick off the cars.
But if you administer edrophonium, the acetylcholine molecules aren't destroyed. They just bounce around in the synaptic cleft, lingering there for much, much longer.
And if they hang around long enough, just purely by random motion, they will eventually bump into one of the few surviving receptors.
Yes. You vastly increase the probability of successful binding, and because the transmitter stays in the cleft, a single molecule might even bind to a receptor fall off and bind to another one.
Oh, wow.
This allows the electrical signal in the muscle to summate over a slightly longer time, eventually dragging the end plate potential back up over that negative 45 millivolt threshold.
The megaphone is broken, but we've basically put the muscle in an echo chamber. The whisper bounces around long enough to wake the muscle up.
That is a great way to put it. The muscle fires normally again, the eyelids open. Now, edrophonium only lasts for a few minutes, so it's mainly used as a diagnostic trick.
So what do they use for daily treatment?
We use longer-acting oral versions of the same drug class, like pyridostigmine. A patient might take several pills a day to continuously suppress the enzyme and maintain their strength.
But this is just symptomatic relief, right? You are artificially juicing the synapse, but the immune system is still actively running its scorched earth campaign in the background.
Unfortunately, yes.
Eventually, if they destroy enough receptors, no amount of lingering acetylcholine is going to help. How do we stop the actual war?
To stop the war, you have to go after the immune system itself. We use systemic immunosuppressants.
Like steroids.
Exactly. Corticosteroids, like prednisone, are very common, or steroid-sparing agents like azathioprine or mycophenolate. These drugs work centrally to suppress the proliferation of the white blood cells that are synthesizing the pathogenic antibodies. You are cutting off the weapon supply.
But those drugs take weeks or even months to fully kick in. What if a patient comes into the emergency room in a myasthenic crisis? Like their weakness has spread to their diaphragm and intercostal muscles. They literally cannot draw a breath.
You can't give them a steroid pill and ask them to wait a month.
Right.
A myasthenic crisis is a life-threatening neurological emergency. Often they have to be intubated and placed on a mechanical ventilator immediately.
So how do you rescue them quickly?
We need acute interventions that rapidly clear the circulating antibodies from their blood. There are two main ways to do this. The first is IVIG, or intravenous immunoglobulins.
What does that do? You're giving them more antibodies?
You are flooding their system with a massive dose of pooled antibodies collected from thousands of healthy donors.
Wait, why does that help?
The exact mechanism is incredibly complex, but essentially this massive influx overloads and downregulates the patient's own hyperactive immune response, and the donor antibodies bind to and neutralize the patient's autoantibodies.
So it's an immune system override.
Essentially. The other option is a physical intervention called plasmapheresis, or plasma exchange.
Like dialysis, but for antibodies.
Very similar. We take the patient's blood out of a large vein, run it through a machine that separates the red blood cells from the liquid part of the blood where the antibodies live.
And you just throw the plasma away.
We discard the antibody-rich plasma and return the patient's red blood cells suspended in a replacement fluid like albumin. You are physically washing the destructive weapons out of their bloodstream.
That's intense.
It provides a very rapid, though temporary, rescue, usually improving their strength in a matter of days.
Now, there's one more therapeutic intervention for myasthenia gravis, and honestly, it reads like a mystery novel. It points to where this entire autoimmune cascade might actually originate, and it involves a gland most people forget exists once they hit puberty. The thymus.
The thymus connection is a profound piece of the biological puzzle.
Explain that for us.
The thymus is a primary lymphoid organ sitting in the upper chest, right behind the sternum. In childhood, it is the master training ground for your immune system, specifically for T cells.
Training them how?
It teaches them how to distinguish between your own cellular proteins, which we call self, and foreign invaders, or non-self.
It's the military academy for the immune system.
Exactly. And remarkably, up to 15% of adult patients with autoimmune myasthenia gravis are found to have a tumor of the thymus gland called a thymoma.
Really? Just a tumor sitting there causing all this?
Yes, and even in the vast majority of patients who don't have a tumor, their thymus is often hyperplastic. It is abnormally enlarged, inflamed, and full of active immune follicles that shouldn't be there in an adult.
So what is happening in the thymus that is making the immune system target the neuromuscular junction specifically?
Within the thymus, there are rare cells called myoid cells. These are muscle-like cells that actually express intact nicotinic acetylcholine receptors on their surface.
Why do they have those?
Normally, this helps teach the developing T cells, hey, this receptor is part of us, do not attack it. This is called negative selection. But in myasthenia gravis, it is believed this training process breaks down.
The military academy gets corrupted.
Exactly.
The T cells see the acetylcholine receptor on the myoid cells, misidentify it as a foreign threat, and graduate from the thymus with a license to kill. They circulate into the body, activate the B cells, and launch a full-scale antibody assault on every neuromuscular junction in the body.
That is the leading hypothesis, and the clinical proof is striking. If a surgeon opens the chest and performs a thymectomy, completely removing the thymus gland, many myasthenic patients see a massive long-term improvement in their symptoms.
Even without a tumor.
Yes. Some even go into complete remission, even if they never had a tumor to begin with. You are removing the corrupted training facility.
It's absolutely fascinating. It really links myasthenia gravis to the broader landscape of systemic autoimmune disease. If your immune tolerance is breaking down to the thymus, it makes sense that you might have other issues too.
It does. It is quite common for these patients to also suffer from other autoimmune conditions like rheumatoid arthritis, systemic lupus, or Graves' disease, which is an autoimmune attack on the thyroid. The central self-tolerance mechanisms are broadly failing.
Okay, we have thoroughly unpacked the acquired autoimmune form of this disease, but now we are going to pivot.
Moving from acquired to inherited.
Right. We are leaving the realm of rogue immune systems and entering the realm of broken blueprints. We are talking about inherited diseases, the congenital myasthenic syndromes, or CMS.
A fascinating set of disorders.
But before we get into the genetics, I want to clarify a massive point of potential confusion for anyone reading the literature. What is the difference between neonatal myasthenia gravis and a true congenital myasthenic syndrome?
It is a critical distinction that every medical student has to memorize. Neonatal myasthenia gravis is essentially a temporary passive transfer of the autoimmune disease.
Passive transfer, meaning the baby didn't make the antibodies.
Right. Imagine a pregnant mother who has active autoimmune myasthenia gravis. Her blood is full of those destructive IgG antibodies.
Okay.
During the third trimester, maternal IgG naturally crosses the placenta to provide the fetus with immunity against common infections. But in this case, the mother's pathogenic autoantibodies cross as well.
Oh, no. So the fetus is bathed in antibodies that attack its own tiny neuromuscular junctions.
Exactly. When the infant is born, they exhibit all the classic signs of myasthenia. They are floppy, they have a weak cry, they have severe difficulty sucking and feeding. It can be quite frightening.
I can imagine.
But here's the key. The infant's own immune system is completely normal. It is not synthesizing these weapons.
So once the umbilical cord is cut, the supply line is severed.
Yes, antibodies have a half-life. As the maternal IgG naturally degrades in the infant's bloodstream over the first few weeks of life, the disease simply vanishes. The baby cures itself completely and permanently. It is a transient, acquired state.
Okay, that makes sense. Now contrast that with the congenital myasthenic syndromes.
Congenital myasthenic syndromes are fundamentally different. They are inherited genetic diseases. The infant is born with a mutant gene from their parents that codes for a defective protein somewhere in the structural machinery of the neuromuscular junction.
So there are absolutely no antibodies involved. The immune system is completely innocent.
Not a single autoantibody. The blueprint itself is flawed.
But clinically, if I'm looking at a baby in a crib, how do these congenital syndromes present compared to the autoimmune version?
Clinically, they look remarkably similar, which is why they were historically grouped together before we understood the genetics. You see a positive family history, usually an autosomal recessive pattern. You see weakness and fatigability that has been present since birth or early infancy.
Right.
You see the classic kurtosis, the drooping eyelids. And crucially, if you hook that baby up to an EMG machine and stimulate the nerve, you will see the exact same decremental response.
Because the electrical failure, the loss of the safety factor is the same, even though the root cause is entirely different. It's like a car engine stalling. It could be out of gas or the spark plugs could be dead, but the result is still a stalled car.
That's a very good way to frame it.
Yeah.
There is, however, one very noticeable clinical difference as the child grows. In congenital myasthenic syndromes, you often see subnormal skeletal muscle development. The muscles are physically smaller and weaker in bulk.
Why is that?
Because normal, robust synaptic transmission isn't just about movement, it provides vital trophic or growth stimulation to the muscle fiber. Because these children have had defective transmission since they were in the womb, their muscles never received the necessary electrical signaling required to build and maintain normal muscle bulk.
Okay, let's open up the hood and look at these genetic spark plugs. The beauty of these congenital syndromes is that the genetic mutations allow us to dissect the synapse piece by a microscopic piece.
Yes, the genetics map perfectly onto the anatomy.
So the failure could be on the nerve, in the gap, or on the muscle. Let's start presynaptically on the nerve side. What can go genetically wrong with the sending city?
The first major presynaptic variant involves a devastating defect in the manufacturing plant. It is caused by a severe deficiency of an enzyme called choline acetyltransferase, or CHAT.
Choline acetyltransferase. Walk us through what that enzyme normally does.
It is the enzyme responsible for synthesizing the neurotransmitter itself. Inside the presynaptic nerve terminal, this enzyme grabs a molecule of choline, which is circulating in the blood, and combines it with acetyl-CoA, which is produced by the mitochondria.
Okay, it puts them together.
It merges them together to create acetylcholine, which is then pumped into the synaptic vesicles, ready for release.
So if a baby has a genetic mutation that cripples this enzyme,
The manufacturing line stops. The nerve terminal simply cannot synthesize enough acetylcholine to keep up with the demands of movement. The synaptic vesicles that fuse with the membrane are essentially empty or severely underfilled.
so when the nerve fires, it dumps a fraction of the normal transmitter into the cleft. The safety factor vanishes instantly.
Exactly. This presents as profound weakness in early childhood, and notoriously, it causes sudden apneic spells, terrifying episodes where the infant simply stops breathing because the diaphragm muscles fail.
That is a failure of synthesis. What is the other presynaptic defect we know about?
The second main presynaptic form is what we call a quantal release defect. In this variant, the choline acetyltransferase enzyme is perfectly fine. The vesicles are completely full of neurotransmitter.
Okay, so they have the ammo.
But the actual number of vesicles, the quanta that are released into the cleft in response to a single nerve impulse, is significantly reduced.
So the nerve just isn't dumping enough of the payload. The trapdoor on the nerve side is sticky.
Precisely. The exact molecular mechanisms for this specific variant are still somewhat elusive and heterogeneous, likely involving mutations in the various proteins that govern vesicle docking and calcium sensing. But the physiological result is a chronically weak end plate potential because not enough transmitter is making it into the gap.
Okay, let's move out of the nerve and into the gap itself, the synaptic cleft. This brings us to what I think is the most fascinating and dangerous part of our discussion today. I call it the pharmacological paradox.
Oh, yes.
What happens if the genetic defect is a missing cleanup crew? What if the infant is born completely lacking acetylcholinesterase in the synaptic cleft?
It is a brilliant physiological puzzle. We talked extensively about how we intentionally inhibit this exact enzyme to treat autoimmune myasthenia gravis. We give them drugs like pyridostigmine to stop the enzyme, increase the acetylcholine in the cleft, and make them stronger.
Right, so my initial naive thought process is, if a baby is born without the enzyme naturally, their acetylcholine must linger in the cleft forever. Shouldn't they be incredibly superhumanly strong? Shouldn't their muscles just be twitching and firing constantly?
It makes sense intuitively, right?
Why does the lack of this enzyme cause profound weakness?
It seems counterintuitive until you remember that skeletal muscle is not designed to be turned on permanently. It is designed for brief, explosive signaling, crisp action potentials.
Yeah.
When you lack acetylcholinesterase, the acetylcholine binds to the receptors and just stays there, holding the sodium trapdoors open for an abnormally long time. The end plate potential becomes massively prolonged.
The electrical signal drags on and on.
Yes. Initially, this might cause the muscle to fire repetitively. A single nerve shock causes a burst of twitches, but very quickly, this sustained depolarization triggers a catastrophic shutdown called a depolarizing block.
How does a depolarizing block work?
The voltage-gated sodium channels deeper in the muscle fiber, which are responsible for propagating the action potential, have an automatic shutoff valve. If the membrane stays depolarized for too long, these channels inactivate.
They just turn off.
They lock themselves shut and refuse to open again until the resting membrane potential is fully restored to negative 90 millivolts. But because the acetylcholine is still lingering and keeping the end plate depolarized, the membrane can't reset.
The muscle essentially short-circuits itself to protect from overstimulation. The electrical wave just hits a brick wall and stops.
That is the electrical failure, but it gets physically worse. This nonstop activation of the acetylcholine receptors allows a massive toxic influx of calcium into the muscle fiber at the end plate. Calcium is a powerful signaling ion, but in excess, it is a cellular poison. It activates internal proteases, enzymes, that literally digest protein.
The muscle starts eating itself from the inside out.
Yes. We call this an end plate myopathy. The ultrastructure of the muscle right at the junction is physically destroyed by the calcium overload. So you have a combination of electrical short-circuiting and physical necrosis, both culminating in severe weakness.
And this leads us to the clinical trap, the paradox. I want to highlight this very clearly. A patient walks into a clinic, they have drooping eyelids, severe fatigue, and an EMG shows a decremental response.
Sounds exactly like MG.
Right. A doctor who isn't being careful might look at that and say, classic myasthenia gravis. I know exactly how to treat this. What happens if a doctor mistakenly prescribes standard MG drugs to a patient who actually has a congenital acetylcholinesterase deficiency?
It would be a catastrophic medical error. Standard MG drugs, like pyridostigmine, are acetylcholinesterase inhibitors. If you give an inhibitor to a patient who is already genetically deficient in the enzyme, you are pouring rocket fuel on a fire.
Oh, wow.
You will completely obliterate whatever microscopic trace of enzyme activity they might have managed to scrounge up.
You will massively worsen the prolonged depolarization, accelerate the calcium toxicity, and drive the patient into a state of profound, likely respiratory compromising paralysis.
Exactly. You would actively harm the patient. It highlights perfectly why treating a clinical phenotype, just treating the symptoms without understanding the exact molecular mechanism, can be so dangerous. Precise genetic and physiological diagnosis is absolute paramount here.
That is a stark, chilling warning. Okay, let's cross the rest of the cleft and look at the postsynaptic receptors themselves. The majority of congenital myasthenia cases are actually caused by mutations directly in the genes that encode the different subunits of the nicotinic acetylcholine receptor.
Yes, the toll booths themselves are defective.
And these fall into two diametrically opposed kinetic categories, slow channel syndrome and fast channel syndrome. Let's start with slow channel. What does that mean?
In slow channel syndrome, the genetic mutation alters the biophysics of the receptor pore itself, often in the alpha helices that line the channel. When acetylcholine binds to this mutant receptor, the channel snaps open as it should, but it refuses to close on time.
So it just hangs open.
Its affinity for acetylcholine is abnormally high, and the channel open time is drastically prolonged.
It stays open for a fraction of a millisecond too long.
And at the nanometer microsecond scale of a synapse, a fraction of a millisecond is an eternity. It creates a physiological environment that is functionally identical to the acetylcholinesterase deficiency we just talked about. The end plate currents are incredibly slow to decay. The membrane stays depolarized.
So it also causes the depolarizing block and the toxic calcium influx, the end plate myopathy.
Yes. The exact same downstream structural ruin occurs. The muscle degrades under the stress of its own overstimulation. Interestingly, the clinical pattern here is often a bit different from autoimmune myasthenia. In slow channel syndrome, severe weakness of the limb and neck muscles is very prominent, but the cranial muscles, the eyes and face, are often largely spared.
That's bizarre. It's the exact reverse of the typical pattern. So how do you treat a channel that refuses to close? We already established that standard MG drugs will just make it worse by adding more acetylcholine to the fire.
You have to find a way to manually close the door, and surprisingly, the treatment of choice is a drug called quinidine.
Quinidine, I recognize that name. That's a cardiac drug, right? Used for heart arrhythmias.
It is a classic antiarrhythmic.
Yeah.
But pharmacology is full of happy accidents. Quinidine has a specific off-target effect at the neuromuscular junction. It acts as an open channel blocker.
How does that work?
When the mutant acetylcholine receptor opens, the quinidine molecule literally wedges itself directly into the open pore of the channel, physically plugging it up like a cork in a bottle.
That is incredible. It prematurely terminates the ion flow, overriding the mutation that is holding the channel open. It artificially restores the timing of the electrical spike.
It is a highly elegant pharmacological rescue. Now, contrast that with the opposite problem, fast channel syndrome.
Fast channel. I'm guessing the door closes too quickly.
Exactly. This is caused by a different set of mutations, often causing the receptor to have an abnormally low affinity for acetylcholine. The transmitter binds, the channel opens, but then it loses its grip and slams shut almost instantly.
So the positive sodium ions barely have time to rush in. The end plate current decays far too rapidly. The voltage spike is tiny.
It fails to reach that negative 45 millivolt threshold. The safety factor vanishes, but this time because the signal was too fleeting, not because it was too prolonged.
Okay, so if the problem is a weak, fleeting signal, does that mean standard treatments work here?
Yes. This is one congenital variant where standard acetylcholinesterase inhibitors do work. By suppressing the enzyme, you flood the cleft with acetylcholine, forcing those fast-closing channels to open repeatedly and rapidly, allowing the tiny signals to summate until they reach the threshold.
But the textbook mentions an alternative treatment for fast channel syndrome that involves a drug called 3-chelin-4-diaminopyridine. And the mechanism for this is fascinating. Walk us through how 3-chelin-4-DAP works.
This is one of my favorite examples of indirect pharmacological workarounds. 3004-diaminopyridine, or 3-4-DAP, does not act on the mutant postsynaptic receptors at all. It completely ignores the structural defect on the muscle. Instead, it targets the presynaptic nerve terminal.
It goes after the sending city. What does it do?
Its primary mechanism is to block voltage-gated potassium channels on the nerve membrane.
Potassium channels. Okay, we need to do a quick neurophysiology review here. During a nerve action potential, the electrical spike traveling down the nerve, there are two main phases.
Right.
First, voltage-gated sodium channels open. Sodium rushes in, and the nerve membrane depolarizes. That's the rising spike. Then, to reset the nerve, those sodium channels close, and voltage-gated potassium channels open. Potassium rushes out of the nerve, bringing the voltage back down to the negative resting state. Potassium is the brakes.
A perfect summary. So if 3004-DIP blocks those potassium channels,
You are cutting the brakes, the repolarization phase is delayed, the nerve action potential is artificially broadened, the nerve stays depolarized for a much longer time.
exactly. Now, why does that matter for neurotransmitter release? Because the fusion of the synaptic vesicles is triggered by calcium, and the calcium enters the nerve terminal through voltage-gated calcium channels. These calcium channels stay open as long as the nerve membrane is depolarized.
Ah, I see the chain reaction. If the potassium block keeps the nerve depolarized longer, the calcium doors stay open longer.
And more calcium floods into the nerve terminal.
And calcium is the trigger. So more calcium means a massive supercharged release of acetylcholine vesicles into the cleft.
Precisely. You are forcing the nerve to shout with a massive megaphone to overcome the deafness of the fast-closing mutant receptors on the muscle. You are bypassing the structural defect on one side by supercharging the normal physiology on the other side.
It is brilliant. It really highlights how deeply interconnected every single ion channel is in this system. All right, we're entering the final leg of our deep dive today. We have talked extensively about failures postsynaptically and failures in the cleft. Now, I want to pivot to diseases that primarily cause presynaptic blockades, diseases that starve the junction of its transmitter entirely.
The presynaptic side of things.
Right. We've seen that in Myasthenia gravis. The EMG shows a decremental response. The signal gets weaker with repetition. But there is a rare syndrome that looks clinically similar but behaves completely oppositely on the electrical tracing.
You are referring to Lambert-Eaton myasthenic syndrome, or LEMS. It is another autoimmune disorder, but instead of attacking the muscle's receivers, the immune system targets the nerve's transmission machinery.
And the EMG and LEMS shows an incremental response. What does that actually look like?
It is the mirror image of myasthenia. If a patient with LEMS is resting, and we deliver a single electrical shock to their motor nerve, the compound muscle action potential we record is abnormally, pathetically small. It barely registers.
Because they are profoundly weak at rest.
Yes. But if we stimulate that nerve repetitively at a high frequency, say 20 to 50 shocks per second, an amazing thing happens. With each successive shock, the amplitude of the electrical response actually grows. It facilitates.
Wait, it gets bigger.
Yes. By the end of a brief 2-second train of stimuli, the final summated potential might be 2 to 4 times larger than the first one.
So the muscle actually gets stronger for a brief moment with rapid, repetitive use rather than weaker? That is wild. Why is the first response so small, and why does it facilitate like that?
The primary defect in LEMS is a severe reduction in the amount of acetylcholine released by the nerve in response to a single action potential. And this happens because the immune system is producing autoantibodies that attack and destroy the voltage-gated calcium channels on the presynaptic membrane.
The calcium channels.
Yeah.
The very doors we just said were the trigger for vesicle fusion.
Yes. The antibodies bind to these calcium channels, cross-link them, and cause the nerve terminal to internalize and degrade them, a very similar destructive mechanism to what we saw with the acetylcholine receptors in myasthenia, just on the other side of the gap.
No calcium entry, no neurotransmitter release.
Yeah.
So when the first shock arrives, there are very few calcium channels left. Not enough calcium gets in, only a few vesicles fuse, the end plate potential is tiny, and the muscle response is weak. That explains the small initial spike. But why does it get bigger with rapid firing?
Because of residual calcium accumulation. Calcium pumps inside the nerve terminal are relatively slow at clearing the calcium back out after a spike. If you fire the nerve at a very high frequency, the second action potential arrives before the calcium from the first one has been fully cleared away.
Oh, I get it. It's an additive effect.
Yes. The little bit of calcium entering with the second spike adds to the residual calcium left over from the first. The baseline level of intracellular calcium rapidly builds up in the terminal. This rising tide of calcium eventually forces more and more vesicles to fuse, temporarily overcoming the blockade and producing that incremental, facilitating response on the EMG.
Now, the underlying cause of LEMS is perhaps one of the most chilling examples of biological crossfire in modern medicine.
Hmm.
It isn't just a random autoimmune glitch. It is often intimately tied to cancer.
It's a paraneoplastic syndrome. A very large percentage of patients, up to 60% who develop LEMS, are eventually found to have a hidden malignancy, most commonly small cell lung cancer.
Wow.
Often the muscle weakness appears months or even years before the tumor is discovered on a scan.
How on earth does a lung tumor cause an autoimmune attack on the nerves in your leg?
Through a tragic biological phenomenon called molecular mimicry, small cell lung cancer cells are derived from neuroendocrine tissue. Because of their cellular lineage, these cancer cells aberrantly express functional voltage-gated calcium channels on their surface channels that are structurally identical to the ones found on healthy presynaptic motor nerve terminals.
The tumor is wearing the uniform of a nerve cell.
Exactly. Your immune system is highly vigilant. It detects the lung tumor, recognizes it as a deadly threat, and mounts a massive aggressive antibody response to destroy the cancer cells by targeting those surface calcium channels.
But antibodies travel everywhere in the blood.
They do. They circulate through the body, they find the identical calcium channels sitting on the healthy neuromuscular junctions, and they attack them with the same ferocity. The paralyzing neurological disease is essentially collateral damage from the immune system's desperate attempt to fight off a lethal cancer.
The body is blinding its own nerves while trying to kill a tumor. It is a profound, tragic irony. Now, there is a parallel here to a very different kind of presynaptic blockade, one that doesn't involve antibodies or cancer, but rather a bacterial assassin. I'm talking about human botulism.
The clinical and physiological parallels between LEMS and botulism are striking, even though the origins are totally different. Botulism is caused by the botulinum toxin, which is an exotoxin produced by the anaerobic bacteria Clostridium botulinum.
Often found in improperly canned foods or honey given to infants.
Correct. It is widely considered one of the most acutely lethal, naturally occurring neurotoxins known to science. A minuscule amount can cause widespread paralysis. Like LEMS, the toxin profoundly impairs the presynaptic release of acetylcholine. And remarkably, if you perform high-frequency repetitive nerve stimulation on a patient with botulism, you will often see a similar facilitating incremental response on the EMG.
But the mechanism of action is completely different, right? The toxin isn't an antibody. It isn't destroying calcium channels.
No, the botulinum toxin is a highly complex protein, essentially a molecular machine. It has a heavy chain that allows it to bind specifically to the presynaptic nerve terminal and get internalized into the cell.
Okay, and then what?
Once inside, the light chain breaks off. This light chain is a zinc-dependent endoprotease, an enzyme designed to cut specific proteins. It acts like a molecular ninja, slipping into the nerve terminal and literally slicing apart the SNARE proteins.
The SNARE proteins, let's explain what those are, because releasing a vesicle isn't just a matter of it floating to the edge and popping. It's a highly mechanical docking process.
It is heavily mechanized. The synaptic vesicles are anchored by a complex of proteins. You have VAMP, or synaptobrevin, on the vesicle itself, and you have syntaxin and SNAP25 on the inner surface of the nerve membrane.
And what do they do?
When calcium enters the terminal, it triggers these proteins to zipper together tightly, physically winching the vesicle down into the membrane until the lipid bilayers fuse and the acetylcholine spills out.
They are the molecular grappling hooks and winches.
Exactly. The botulinum toxin specifically targets and cleaves these SNARE proteins. Different strains of the toxin cut different proteins. Botulinum toxin A cuts SNAP25, toxin B cuts synaptobrevin, but the result is the same.
The grappling hooks are severed, so the nerve action potential arrives perfectly fine. The calcium channels open, the calcium floods in, but the vesicles are physically trapped. They can't dock, they can't fuse.
No release.
The acetylcholine is locked inside, streaming to get out, but the exit door is permanently sealed.
The release machinery is snipped apart at the molecular level. It is a brilliantly effective blockade.
So we have two profound presynaptic blockades, MMS and botulism. Because they both result in starved junctions, how do their clinical treatments contrast?
Because both involve a failure of presynaptic release, you can try to use drugs that aggressively promote acetylcholine release to temporarily overcome the blockade.
Like 3,4-DAP, which we discussed earlier for fast channel syndrome, cutting the potassium brakes to force more calcium in.
Yes. 3-Silane 4-DAP is often highly effective at improving strength in LEMS patients. You can also use other agents like calcium gluconate or guanidine. However, because LEMS is an autoimmune disorder driven by a chronic underlying condition, usually that hidden lung cancer symptomatic drugs are only a band-aid.
You have to find the cancer.
Right. Long-term management requires finding and aggressively treating the underlying tumor. If you eliminate the cancer, the immune system often stops making the cross-reacting antibodies. You may also need chronic systemic immunosuppression.
So you have to stop the factory making the weapons. Whereas botulism is an acute poisoning event. It's a hit and run by a bacteria.
Exactly. Botulism is transient, though it feels anything but transient to the patient. The nerve terminals are chemically paralyzed, but the nerve cell itself is not dead. The recovery is a race against time.
What happens during recovery?
If the patient is medically supported, which very frequently requires mechanical ventilation in an ICU for weeks to keep them breathing while their diaphragm is paralyzed, the nerve terminals will eventually recover. The nerve will sprout new, unpoisoned nerve endings, synthesize fresh SNARE proteins, and rebuild the fusion machinery from scratch. The disorder resolves completely in weeks or months as the anatomy meticulously reconstructs itself.
Wow. Okay. We have covered an immense amount of microscopic ground today. Let's briefly pull the camera back and recap this journey across the synaptic cleft.
It's been quite the journey.
We started by looking at how failures postsynaptically, whether from the scorched earth autoimmune destruction of receptors in Myasthenia gravis, or the mutated hyperactive channels and slow channel syndrome, lead to profound weakness because the muscle simply cannot hear the nerve signal clearly.
Right, the receiver's broken.
We saw how a defect in the cleft itself, the absence of the clearing enzyme, causes a toxic, self-destructive overstimulation. And we just finished seeing how presynaptic failures, from cancer-driven molecular mimicry destroying calcium channels to bacterial ninjas snipping the SNARE proteins, starve the junction of its vital chemical messenger.
Presynaptic, cleft, and postsynaptic failures. They all yield profound, paralyzing muscular weaknesses, but each does so through a distinct, mesmerizing mechanism.
And returning to the thought we opened the show with, I think what this deep dive truly underscores is the extreme, almost terrifying biological precision required for human movement.
Every single time you casually lift a coffee cup or blink your eyes or take a breath in your sleep, you are relying on an incredibly narrow, volatile biological threshold.
A safety factor that is robust on paper, but ultimately incredibly fragile in reality.
Exactly. Think about the margins we discussed today. A slight widening of a microscopic cleft by just a few dozen nanometers. A mutant protein that causes an ion channel to close a fraction of a millisecond too fast. Or an antibody valiantly fighting a lethal tumor in your lung that accidentally cross-reacts with a calcium door on your nerve.
Any single one of these.
Any single one of these microscopic deviations, these invisible biochemical errors, can completely sever the brain's command over the physical body. Studying these diseases highlights not just the fragility of our biology, but the everyday, completely unrecognized miracle of an intact, functioning nervous system.
The everyday miracle of the safety factor. The fact that the megaphone works at all. That is a brilliant and provocative thought to leave you to mull over. The next time you effortlessly reach out and grab a pen, just take a second to appreciate the millions of acetylcholine molecules perfectly navigating the abyss, hitting their targets, and pulling the electrical trigger in perfect unison.
It's truly amazing.
That concludes part 2 of our Chapter 57 exploration. Tune in next time to the deep dive here on Enkephalikos, where we will finally cross the junction completely and look at the primary diseases, the skeletal muscle itself, myopathies, and dystrophies. Until then, keep wondering about the incredible microscopic machinery operating inside you.